time. Let's go to our next speaker, Dr. Shih Chen from Taiwan, and I think he'll really give some important tips and tricks for the management of the slippage of GRT, which is again another nightmare which can happen.
Thank you, Bhuvan, for asking me again for this nightmare symposium. Can I have my slide? Yes. Okay. So I'm going to talk on the slippage of giant retinal tail during the surgery. What do we do next? So this is happen in the case after you inject the peripheral carbon, flatten down the retina, and then doing the free gas exchange, and then you happen to have this slippage. Now, in that way, you cannot use your back thrust to unscrew the retina again. You can see that's actually very heavy. So it turned out that the patient have a big fold like this. So every time I see this patient, I feel very sorry. Although the central visual acuity is okay, but it have some field defect. So what happened for this the slippage is that because you have incomplete subretinal and vitreous fluid removal. So the aqueous, when you have the peripheral carbon, the surface tension of this retina is actually, the flap is actually sit on the peripheral carbon, and then you have a space for the aqueous. And when the air come in, and then you can see that the subretinal fluid was sequestrated underneath the retina, and then when you are going further with the gas, this fold because of the gravity, they come lower even onto the macula. So David Wang suggests that if you want to have the peripheral carbon liquid, you should have this peripheral carbon injected until it comes up from the infusion channel stroke, so that makes sure that the eye is totally filled with the peripheral carbon. So when the macula is on and the slippage is mild, so what should we do? In this case, you can see that when we open up this retina, there's some grayish shadow at the side posterior to the retinal break. And this area actually have some intraretinal contraction, like a PVR change. So I made some radial cut for these patients. I try to conform this shape of this detached area to the choroid. And when I saw this picture, you see that actually the radial cut is not deep enough, so I should extend until the edge of this detached, PVR area. So you can see that you can have a better perform this retina. And then when you try to have this free exchange, be careful that you have to put your extrusion tip from the posterior to the anterior, so that you can make the retina sitting well on that. So why is that we use a radial cut? For example, you can see that this radial cut can open up the inward tension and drain the posterior subretinal fluid. So you have A and B. If you cut deeper, then you have more chance to aspirate the trapped subretinal fluid. And this will be shown in the mathematical model for a 90-degree tail without or with radial cut. So if you have no radial cut, the gravity will draw the subretinal fluid towards the posterior. You have a radial cut for 3 millimeter, it's like this. A deeper radial cut, you can have a less subretinal fluid trap at the center. So if the fold is not great enough, it's at the side of this macula, it's an extra macula area, then probably you can have some retinotomy here, drain some fluid, but still the slippage was folded, and then you have a epiretinal membrane, a large pucker for these patients. So the other way is that you can have this air-oil exchange to alleviate the slippage. For example, in this case, you can see that after the peripheral carbon liquid, try to have this free gas exchange. And you can tell that during this free exchange, even with I very carefully drain the subretinal fluid, there's still fold over the area. In this case, I changed to a silicone oil, and then the fold became less. So the reason for this is because of the buoyancy force, and the surface tension force is different between the silicone oil and the air. So you can see that on your left side, you see this air is have a very strong buoyancy, and then also the tension. So on your right side, you see this folding here. So the fold depends on the force in the posterior part, posterior to the fold, and also the anterior to the fourth. And also you have a buoyancy. And because of the silicone oil, it have a less force and less buoyancy, so you can have this less severe retinal fold. So in case of that, you see the fold, probably can change to silicone oil. The other thing is that this has happened when I have these patients. The patient have a lower retinal detachment and anterior PBR with silicone oil. So this patient come to me, and I try to think that maybe after this relaxing retinotomy, I can just inject the peripheral carbon underneath the silicone oil to the tamponade and flatten down the retina underneath. So I inject the peripheral carbon underneath the silicone oil after the lower retinectomy. And it happened that the adhesive silicone oil and the peripheral carbon became a large bubble, and because of the buoyancy of the silicone oil, this big bubble float up, and it takes the retina detached from the posterior. So then I have to aspirate the silicone oil to decrease the buoyancy, and I make more radial cut for this patient, and finally I flatten down the patient, and then I do the oil exchange, the free peripheral carbon and the silicone oil exchange to flatten down the retina. So what happened, what is the mechanism for this? This is called a sticky silicone oil syndrome. So when you have the peripheral carbon at the base, and then also the silicone oil, if the silicone oil has a very good contact with a large amount of peripheral carbon, it will look like this, a big bubble. So this is buoyancy of the silicone oil is not sufficient to overcome the interfacial energy. So we have this case like I shown. But in other words, we can use this as to squeeze out the subretinal fluid. So when you have an oil-oil exchange, you have a silicone oil coming in instead of, and you contact with the peripheral carbon. Then they form a very smooth surface that can squeeze this subretinal fluid. So make the slippage less likely. I want to show another case. This is a patient with a chronic retinal detachment. This is pre-op picture. You can see this previously have a big hole there. And I tried to peel the anterior PBR, which was hard to be released. Then I follow this with relaxing retinotomy. And I also do some radial cut, try to flatten down this relaxing retinotomy. This the giant tear I created after the retinectomy. And then I keep on working on the anterior PBR. Then I inject the peripheral carbon, and then continue to peel the membrane like this. And I have a high buckle for this patient. Now I start to have the anterior PBR at the lower retinectomy. Then I use a frequency exchange under the peripheral carbon. Also, oil exchange to avoid the slippage of this retinal fold. And the patient become okay after this surgery. And this has a post-op 3 days. And this 22 months later. I still have some useful vision, although the retina of the macula is still very thick. So you can see that the buckling prevents the anterior PBR happen in the superior part to involve this macula. And although there are some PBR change at the nasal side, is okay for these patients. The other thing, the last thing I want to show you is that you can also perform the two-stage procedure for this kind of PBR to avoid the slippage. Now this is a 30 cases retrospective study from the Belfast. And they use that peripheral carbon not only in the intraoperative tool, but also the short-term post-op temporary for 1 week. So after 1 week, they take out the peripheral carbon and they inject the gas or silicone oil. By doing this, they decrease the rate of slippage, which is 0% for this kind of a procedure. And they have a redetachment for 9%. Then have a silicone oil tamponade compared to a traditional one-stage procedure. They can have the silicone oil tamponade for only 23% of these patients, compared to the previous one-step procedure is 80%. And also, especially for those fresh cases without a macular involvement. So as Boomer already showed, if you put the peripheral carbon for 1 week, you will see some mild anterior chamber inflammation that can be easily controlled by the topical steroid. And during the 30 cases, one case I have a persistent perfluorocarbon drop it in the anterior chamber. So what if you have done perfluorocarbon and you have to have this inferior relaxing retinopathy? This is a case shown by Professor Shih. She showed me that you can have this pre-pressed diastemy, and then you have a fluid exchange drainage from the posterior retinotomy. Then after the air filled in, you can have start your relaxing retinotomy. So the retina will be contracted toward the posterior, but you can still have this procedure after the laser and then the silicone oil. So in summary, to prevent the giant tail retina slippage, you should dry the subretinal fluid and vitreous aqueous as much as you can, and radial cut to make this flap more confront, more well fit to the colloid. And you have a silicone oil temporary to decrease the fold, and also a silicone encircling barcode to avoid the future PBR changes if this patient already have some PBR. And during the intraoperation, macro fold, if you happen, I think you have to re-inject the perfluorocarbon to release the fold. It's not easy for a macro fold to be flattened down. If it is an extra macro, leave it. You can use a very small retinotomy and change to oil temperature to flatten down the flap. And then you leave the perfluorocarbon. This is another choice for 1 week, and you have the second surgery for the gas exchange or silicone oil exchange. So I want to thank my colleagues, and thank you for your attention.
Thank you, SJ. Excellent presentation. I think very useful tips. And I think those radial cuts, they are really very helpful. I routinely do it even before I do a fluid exchange. They really prevent slippage. I just have one question for you. What intraocular tamponading agent would you decide for your GRT cases? Not the complicated ones. Which is your preferred intraocular tamponading agent?
I'm sorry, you mean which kind
Gas
of
or silicone oil at the end of the surgery? Which would you like to use and why?
Yeah, like I said, I mean, if you happen to have a slippage, then probably you can shift to silicone oil to decrease, to a compression of the fold. But anyway, I mean, this two-stage paper show that if that is the case, and it is a very fresh retinal detachment, the macula was well attached, and you think that this probably will cause a slippage. So maybe you can leave the perfluorocarbon there for 1 week, and then go in.
So that is your preferred approach now? You prefer to leave?
Actually, I haven't tried this two-stage before. So I'd like to try that. But anyway, I think I will try to avoid the slippage as much as I can. So, and then change to gas if it's a fresh case.
So I have done few cases with the two-stage, and I think it works really good. I think Andrew also must have done it. There are a few papers from Australia also. And I think it really works very well, especially in young patients who have a very high chance of developing PVR and contracture and slippage. It really prevents the risk of redetachment.
Yeah, it's a really nice technique, but you do have to go in a second time. So there are, convenience and cost issues to go back in. Just one question to you. Macular fold after regular detachment repair. How do you reduce that? I'm not, like in terms of post-operative posturing, how much fluid air do you do? Because that's actually a really big issue if the macula's split or just off and the next day you have a fold through it.
Yeah, are you meaning the intraoperative or post-op you happen to see the fold?
Post-operative, you see the fold.
Well, that's very difficult. I think you have to go in and then inject the fluid, the BSS, to the macula, detach the macula, and then the perfluorocarbon again, and then try to flatten that.
Sir, I said as I would always prefer gas only if there is no slippage, and if I'm leaving PFCL, then also I would probably, for a young patient, I would probably, first again gas only, but for a young patient probably I'll go for silicone oil because both positioning and follow-up is slightly difficult. Yeah, I agree with you, but my preferred approach is I do a PFCL. I always, even if I'm using silicone oil, I will always do a PFO air exchange to see whether there is any risk or not. I've relieved all the traction or not. I don't prefer to do a PFO silicone oil exchange direct.
I have one small question to Sir you and panelists. Sir, how you decide how many radial cuts for a particular degree of GRT, like if it is 180 degree or 270 degree, the white portion you were showing in your video, how to decide and how deep we have to make the cuts?
Yes, like I show, I mean, it depends on the how big is the extent of this radial cut. And then I know there's one doctor, he showed us that you can just make a long radial cut at the edge of the tail. But I mean, even if you're doing that, when you are trying to spread, doing the free gas exchange, you still see some folding of the flap. So I think that's the time that you start to do the radial cut. So sometimes I just make this after the purple carbon, and then I try to see during the free gas exchange, I try to see if the flap is coming, I mean, the folded. So in that case, I will do that area, the most depending part to do the radial cut. If it's not enough, and then I'll do another one.
Sir, there is a PVR in the margins of the fold, and many times we cauterize and trim that. So we are doing that step also, and we are giving radial cuts also. Like both the things, or it is like one is going to substitute for that step.
I think if it already have some PBR change, that would be much more difficult, and maybe the radial cut should be deeper. So yeah.
I think radial cuts, they have a different role also. So there are two tractions which act in GRT. One is a longitudinal traction and one is a radial traction if there is PVR. So I think radial, with the radial, these cuts, you reduce the radial, the tangential traction also. So we are reducing two forces. So if you saw in the video also, the retina tends to open up like this.
Yes, sir.
So there are, if you're trimming the edges, I think these radial cuts,
It
they
is for the
relax it. Yeah, they relax it
intra-retinal
radially, tangentially. So always they will always gape. So in slightly old cases, there is always some contracture tangentially also. So I think you should do these radial cuts along with the trimming of the margins.
And how many? Like
How many? I think it depends. You can't define it. I think it will depend on the amount of PVR and shortening which is there. For a very simple case, what I prefer is I'll make two at the edges and one in between or two in between. But probably if the PVR is severe, then probably you have to make it for about 2 days diameter and also increase the number of them. But I think it's very difficult. It has to be decided intraoperatively only. Like a retinectomy. You can't pre-decide a retinectomy.
Thank you, sir.